Okay, so now we will be looking at jaundice and its type and the metabolism of bilirubin. Jaundice refers to yellow discoloration of skin, sclera, and mucous membrane. It is increase in bilirubin concentration in the body and detectable when a bilirubin level exceeds more than 40 micromillimole. And the bilirubin metabolism is there is unconjugated bilirubin and conjugated bilirubin. What is difference between unconjugated and conjugated? In unconjugated there is indirect bilirubin which is lipid soluble and it is end product of heme degradation. Now look at the metabolism of heme. When RBCs are broken down, then RBC releases hemoglobin and heme and globin. Okay, so hemoglobin is broken down into globin form and heme is broken down into porphyrin and iron. Iron is reabsorbed back and porphyrin is broken down into bilirubin which is unconjugated, and then it goes into liver for conjugation, and then conjugated bilirubin is released from liver into small intestine and it is excreted through stacobilinogen, and then some of it is reabsorbed in the kidney and released as urobilinogen. Now there are certain diseases which causes unconjugation problem, which causes problem in the liver, then bilirubin develops. Other disease causes problem here, blockage occurs, and then bilirubin increased, and in this way the disturbances and problems arise. Now we will look at the conjugated bilirubin which is coming from liver, and it is water soluble and it is formed via unconjugated bilirubin hepatic UDP glucuronide transferase enzyme. So it is water soluble and is loosely bound to albumin, and excess of conjugated bilirubin plasma can be excreted in the urine as well as from stercobilinogen formed in the feces. So it is stored in gallbladder and released into duodenum via common bile duct and converted into urobilinogen in small intestine and then released. So what happens? Some of the problems arise in gallbladder, some of the problems arise in small intestine, and excretion problems come arises, and in this way bilirubin excretion is stopped. Now we will look at unconjugated hyperbilirubinemia. There are two types of unconjugated hyperbilirubinemia, that are hemolytic jaundice and congenital non-hemolytic jaundice. We will be looking at this. Hemolytic jaundice is increased production of unconjugated bilirubin, means extravascular hemolysis occurs, and extravascular hemolysis includes all these cause. I will not tell you all single cause because it will divert your mind. So lay finding in unconjugated hyperbilirubinemia will be conjugated bilirubin is less than 20%, urine bilirubin is absent, urine urobilinogen is dark in color, liver enzyme is elevated AST. So in this way unconjugated hyperbilirubinemia occurs. Now conjugated non-hemolytic jaundice occurs. Congenital non-hemolytic jaundice occurs when bilirubin is less than 20, urobilinogen is absent, urine urobilinogen is normal, liver enzymes normal, because problem is in the vessels, not in the liver. What we did, we saw that this is liver. Here bilirubin is unconjugated. Now problem is here, means the liver is not involved, so all the things of the liver and after the liver will be normal. So these are the types of unconjugated hyperbilirubinemia, like Crigler-Najjar syndrome. It is congenital in fetuses. It causes kernicterus, and treatment will be phototherapy, exchange transfusion, and liver transplant. Crigler-Najjar syndrome type 2, it is autosomal dominant, causes jaundice, and type 1, kernicterus is not common, treatment is oral phenobarbital. Gilbert syndrome is also congenital and a benign disease occurs. Bilirubin is unlikely elevated, jaundice occurs, and alcohol fasting, strenuous exercise, and intercurrent illness can give rise to this. No treatment is necessary. Hepatocellular jaundice is the inability of liver to transport bilirubin into bile duct. Now, hepatic, it is involved in the liver. Because of viral hepatitis, it can occur. Because of alcoholic hepatitis, it can occur. Other is cholestatic or obstructive jaundice, in which what happens, there is obstruction of unconjugated bilirubin arriving at the liver. Causes are drug-induced oral contraceptive, primary biliary cirrhosis, autoimmune hepatitis, congenital conjugated hyperbilirubinemia, Rotor syndrome, and Durbin-Johnson syndrome can cause this condition. Lab findings will be conjugated bilirubin greater than 50, urine bilirubin is increased, urine urobilinogen is absent, liver enzyme will be elevated, AST, ALT, ALP, GGT will be elevated. Obstructive jaundice shows jaundice, pruritus, dark urine, pale stool, xanthelasma, xanthoma, malabsorption, and fat-soluble vitamin A, D, E, K, weight loss, dysphoria, osteomalacia, and bleeding tendency. In this way, this present. So in this way, we looked at the unconjugated bilirubin and conjugated bilirubin. So this was all about hyperbilirubinemia.